I think like everybody, we were under the assumption that early intubation was key when they first came in. So the first few we saw, we were probably being a little bit more aggressive about. So we used that early on, and we had a lot of pushback very early on from respiratory therapy, some of which misunderstood the guidelines and thought everybody should be intubated with no role for either non-invasive positive pressure ventilation or for HVNI.
This is Velocity from Vapotherm. In this series, we join conversations with clinicians, educators, and researchers to explore topics of respiratory care. Today, we join 5 ED physicians reflecting on their experience with the COVID-19 pandemic so far. We'll be joining these physicians over the next few episodes. Today, they're discussing the signs and symptoms presenting with their COVID-19 patients and how approaches to treatment have changed as more information and guidelines have become available. Today, you'll be meeting Dr. Kirk Hinckley, Dr. Adam Hennessy, Dr. Michael Bubowitz, Dr. Ross Simcoe, and Dr. Mark Gebhardt, who it's worth noting for those of you watching on YouTube, he makes excellent use of Zoom backgrounds. So, way to go, Dr. Gebhardt. Dr. Hinckley, as you'll hear in a moment, is a member of the Vapotherm team as Director of ED Education. The rest of today's participants are paid consultants. And while we're speaking with doctors today, it's worth noting that Vapotherm does not practice medicine, provide medical service, or medical advice. Any clinical recommendations in these episodes are solely those of the speaker. For any devices you hear mentioned, please refer to the instructions of use before use. Now, let's join Dr. Hinckley.
I'm Kirk Hinckley. I'm the ED Director of Education for Vapotherm. I'm also a practicing ED physician. I work at 2 smaller ERs in northeastern Pennsylvania. One is Barnes-Kasson Hospital, the other is Tyler Memorial Hospital, and then one large academic center at the Penn State College of Medicine, the Hershey Medical Center.
My name is Adam Hennessy. I live in Philadelphia, Pennsylvania, and I work at Our Lady of Lourdes Medical Center in Camden, virtual Our Lady of Lourdes, where I'm assistant director and a full-time ED attending.
Michael Bubowitz, ER physician. I practice in the Houston area, working for the Memorial Hermann system. I've got operational control over 20 community EDs. And for Team Health, I'm what's called the Regional Performance Director for the West Group, and effectively an internal Team Health consultant helping with operational improvement and performance across the entire book of business on the west side of the country.
Mark Gebhardt.
Yeah, I'm Mark Gebhardt. I'm an emergency medicine physician and associate professor at Boonshoff School of Medicine, Wright State University in Dayton, and I clinically practice at Atrium Medical Center in Middletown, Ohio.
And Ross.
Hi, I'm Ross Simcoe. I work with Adam at Virtual Our Lady of Lourdes in Camden, New Jersey. There's also a couple other sites that I work at, including Chestnut Hill Hospital, which is on the outskirts of Philadelphia, right along the Philadelphia County and Montgomery County border. And then I work at a critical access hospital in north central Pennsylvania at an 8-bed ER with a hospital with about a 25-bed inpatient capacity.
Great. And Mark, we'll stick right with you. How would you characterize the respiratory distress in the patients that you've seen with COVID? What kind of symptoms and signs are you seeing in these patients?
Out of the few that we've admitted, and I did see one yesterday, what I have seen clinically is hypoxia in individuals who don't appear to be in respiratory distress when at rest. And that's been in most cases what I've seen. So people who present, a 43-year-old yesterday presented with a resting saturation rate of 77%, but he did not appear dyspneic when he was at rest. And he would relate to us any sort of exertion would provoke dyspnea, but an otherwise healthy middle-aged adult who simply presented with hypoxia, and then surrounding the illness was about a 48-hour period of subjective fever and feeling ill. That's most of what I've seen, Kirk.
Yeah. And Mike in Houston, any cases you've seen?
It's pretty much a similar situation for the younger folks. The older population tend to present, at least in where I do most of my clinical work, and more of what you would see in a respiratory distress with a pneumonia. Occasionally, we've had some of the GI folks without any respiratory symptoms. We've had some generalized weakness, that sort of complaint that you would expect in undifferentiated septic patients coming from nursing homes. We've had a few clusters in the northern part of Houston, near the Woodlands. And then in a little pocket on the west side of Houston as well. It's a nursing home cluster. So that's sort of that spectrum. But the young folks, I agree with Mark, it's a very odd presentation when they're resting and they're not walking around, look quite comfortable and do not match the monitor. As soon as you get them moving at all, that just plummets. So that group tends to do pretty well with the supplemental oxygen that we're able to provide them in a variety of ways.
And Ross, in Philadelphia, I know you guys are a little bit further along. So any changes that you've seen from what they just described?
No, I think we're seeing kind of a full spectrum of disease. We're seeing or even middle-aged patients that actually sometimes come in for a different reason. I saw a younger female yesterday who came in for belly pain and had a resting pulse ox of 84%. So kind of what Mark had mentioned, these people don't even seem to realize that they're hypoxic. And then I've seen people that I've intubated the minute they hit my door. I put a PAPR on and intubated them. I know we're trying to get away from the early intubation, and we're going to talk about that a little bit later, but I've seen the full spectrum of disease, people that are crashing to people that don't even really fully know they're sick.
It's humbling the variety of presentations this disease has. I had a patient present as an MS flare that turned out to be COVID. And then, of course, once we made the diagnosis, our oxygen level dropped, as it tends to do in the ER. A lot of the patients that seem well, and then you realize that their pulse ox is in the 70s or 80s. And just like Ross said, people that just come in super sick or just turn on a dime. They don't have much reserve. They're kind of hanging right on the edge of that oxygen dissociation curve, and you don't really have much room to work with. But yeah, I've seen both the end progression, the really sick ARDS type picture, as well as the earlier manifestation of just the hypoxia. And you just have to, I think it's just staying aware that it can present as anything is what we need to keep an eye out for. And just the other day, I had a gentleman who was 82 and dizzy as his only symptom, and he was COVID positive with ground glass opacities on CT.
Yeah. So what I would tell you, the most recent case I saw, we are covering the walk-in clinic now with the volumes being down as well. So I had a patient walk in on Monday afternoon with her original complaint was diarrhea and mild cough, 46 years old. O2 sat on arrival was 90, not terrible, but we walked her maybe 25, 30 feet and she dropped to 86%. So we have the resources, we're onesie twosies at this point, and so we worked her up and CT scan, very typical appearance of a COVID lung. So of course she ended up being positive. So we'll keep it right with you, Adam. And what is your hospital's current approach to treating these COVID patients with respiratory distress? And, how over the last month or so has that changed? Have you guys used any of the specific health organization or specialty guidelines, such as the SCCM or WHO, CDC guidelines, in the way that you've adapted your treatment?
Yeah, specifically in the ER, we're kind of at the cutting edge of that early on too. I think like everybody, we were under the assumption that early intubation was key when they first came in. So the first few we saw, we're probably being a little bit more aggressive about. And we are a pretty aggressive HVNI department. So we used that early on, and we had a lot of pushback very early on from respiratory therapy, some of which misunderstood the guidelines and thought everybody should be intubated with no role for either non-invasive positive pressure ventilation or for HVNI. So using both the World Health recommendations as well as the surviving sepsis guidelines for COVID-19, we've been able to encourage more and more people, support staff and patient staff, that it's a completely safe modality. So I would say unless you're on and it's been like this for the last several weeks, unless you're in fluid respiratory distress that you clearly need intubation, nobody's pretty much going on BiPAP, and everyone's either going on either low flow nasal cannula, but if they need above probably, I don't know, Russ might have to that too. If they're not going above 4 liters, or if they need more than 4 liters nasal cannula, they're pretty much equivocally everyone's going on to HVNI therapy. And I would say we've been pretty aggressive about that over the last several weeks.
All right, Ross.
Yeah, so just being at multiple sites, I can say that the ER seems to be on the cutting edge at all of the hospitals that they work at, that are kind of pushing for policy updates and getting the rest of the hospital and or respiratory therapists communities to agree that high velocity and or high flow is a safe therapy to use. I quote and show the references anytime people would come up with questions about that for the Society of Critical Care Medicine, WHO, ASAP. Everyone has a statement out there right now pretty much saying that high velocity nasal insufflation may be the go-to therapy, but it's certainly an acceptable therapy. But I'm still trying to fight this fight. Just yesterday, I asked a respiratory therapist to put someone on. There, it's high flow. It's not high velocity. They don't have Vapotherm, at least not many units at that institution. And I wanted them put on high flow more to help with the work of breathing. And he said, "There's no way I'm going in there and risking putting myself and the rest of the staff at risk by putting her on high flow." And I said, "Well, what would you prefer to do?" And he said, "I would prefer to put her on BiPAP." And at that point, I had to sit him down and do a little education and show him some of the slides about the aerosolation distance of particles using things like BiPAP versus high velocity versus nasal cannula and non-rebreather. There's some really good graphs out there that I'm sure you guys have seen, and maybe we could reference for anyone looking at this at home. But yeah, I'm still fighting as of yesterday to convince people that this is a safe modality.
Mark, you're medical director in Dayton. How about your hospital's approach?
We were, before COVID, we were I think in our region, an early user of HVNI and had been on board with Vapotherm. So we had widespread acceptance and socialization of HVNI, especially amongst our respiratory therapists and our intensivist colleagues. But I'll tell you, I echo some of the sentiments of you all. My respiratory therapy department reeled back as COVID took off. And I had similar experiences to what you described, Ross, where I had a respiratory therapist 2 days ago absolutely draw a line in the sand and refuse to use HVNI, and said, in fact, to me, that I was putting everybody at risk by prescribing that treatment modality. So I had to do the same thing. I had to reference some of the current literature, and I actually pulled out the pictures and actually physically showed her what would happen by deploying HVNI with a mask underneath, and started to make some headway. But we've had a little bit of a trouble reorienting a very concerned and emotional group of respiratory therapists. Medicine, on the other hand, I think embraces the idea, but we've just gone through some workforce issues that we're still actively working to correct.
So Houston, we've sort of evolved, I guess, over the last month or so in our approach, much like many other sites. And the chatter's getting out there now. Early on, we intubated early on. That's sort of what we learned from the Italians, that we learned from the experience in Washington, realized that maybe that isn't the best thing to do. And so over the subsequent weeks, started developing alternative protocols on how can you safely use non-invasive, how can you safely use HVNI, how you can safely use high flow nasal cannula, et cetera. So a variety of different ways, more and more of because we have so many EDs within the system, a lot of the innovation comes from the academic medical center, and that's where a lot of these protocols are coming from, and the community hospitals weigh in on it. So they tend to be the first ones to adopt some of this, and then the community hospitals follow suit. I will say this, that a lot of various innovations have come out of each of these practices, the community and the academic center alike. So we've got everything from low-tech solutions, these constructed frames and plastic hoods that we put over these patients where we're giving nebulizer therapies to, and masks for the HVNI and high flow, et cetera, that help add that extra layer of protection to staff. we are in the fortunate position of having a very good supply of PPE within the system. The hospital system has procured the necessary equipment to keep the staff safe. Adopting these modalities has been less challenging, as we do have reasonable supply of negative pressure rooms, of PPE, et cetera. So our system is not yet overwhelmed. It does allow us to maybe innovate a little bit more with regard to using HV&I, using these other sort of non-intubation modalities.
Yeah, and I know it's really been helpful for me in getting the message out to have these major organizations kind of fall into lockstep with one another. So SCCM, WHO, CDC are kind of all in agreement at this point, which was not really the case early on. And now ASAP has come out with a field guide, which kind of echoes and follows along all those guidelines.
Bit of a hard stop there, and the reason why is the next question that Dr. Hinckley challenges our guests with happens to be my personal favorite question, and you'll just have to wait until the next episode to hear what it is. It's not long of a wait though. We're doing this more like a Netflix and less like a cable series, so you'll be able to go find it right there. It's already waiting for you, wherever it is you're watching or listening to this podcast. So if you're watching on YouTube, it's the next video in the playlist. If you're listening on Stitcher, it's probably already waiting for you. The same with those of you on Google Play, iTunes, etc., etc. Now, if you're finding us for the first time and you're like, oh, I didn't know this was available on all those platforms. Maybe you're watching on Facebook. Come on over and find us at vapotherm.com. At vapotherm.com, you'll find information about Vapotherm high velocity therapy that was mentioned a few times in this conversation so far, as well as links to other educational resources like the Vapotherm Academy, which for RTs and nurses in the audience does have continuing education credits available for you, as well as our blog and this series, Velocity, it's a plethora of stuff, guys. Please come check us out. Thank you for joining us for this episode of Velocity. Next episode is coming out right now on your playlist.